Good morning to all. I'm presenting the study on our olanzapine in moderately emetogenic chemotherapy, that is OMIC study. Next, please. As we all know, emetogenesis is classified into three groups largely. High, that is more than 90%, moderate, which is 30 to 90%, and low, that is 10 to 30%, and very low is less than 10% in the absence of any antiemetic measures or medications. So this moderately emetogenic class is 30 to 90% is a mixed bag of regimens with majority of commonly used regimens belonging to this class with varying incidence of CINV and currently used antiemetic protocol as per the ASCO and NCCN guidelines. Majority of the clinical trials that we have now focus on highly emetogenic class of the drugs, that is mostly containing AC and cisplatin as the predominant regimens, and moderately emetogenic is the less addressed group amongst these drugs. Next, please. So the current recommendation for moderately emetogenic is 1,5-HT3 antagonist with previous one, please. Is the three drug is the standard regimen. With our study, we are aiming to add fourth drug, that is olanzapine, to the current standard of care to reduce the incidence. Because we know that with some agents, particularly with irinotecan or oxaliplatin combining, or with these agents combining with some other agents, these have CINV incidence of around more than 60 plus percentage. That is, this can be classified as high moderately emetogenic drugs, and about 20 to 30% of patients fail to achieve CRs in these regimens with current anti-emesis practice. So lack of control of nausea is one of the reasons for lack between control of vomiting and CR rates. For most of the studies, the CR rates takes into account the control of emesis and nausea not requiring any medication. So nausea is relatively less addressed upon component in all the studies. So olanzapine is an atypical antipsychotic agent which blocks multiple dopamine brain receptors in addition to the 5-HT3 receptors, acetylcholine muscarinic and H1 receptors. It has additional anti-anxiolytic effect, some effect on pain, some effect on cognitive impairment, which are the additional actions. We are taking olanzapine considering for this agent in view of its low cost, its acceptable safety profile and tolerance with relatively mild side adverse effects with less than 5% incidence of significant side effects, mainly consisting of somnolence, increased risk of extrapyramidal symptoms, which is less than 1 to 2%, weight gain, increased risk of diabetes mellitus with prolonged use, even more than 6 months of use, which is not what we require, postural hypotension. However, in anti-MSS studies, daytime sleepiness was the most significant adverse effect, most commonly on day 2. So our study is a randomized controlled trial based previous one. Based on the hypothesis that addition of olanzapine will reduce or improve the CR rate in moderately emetogenic drugs. Our study design is a prospective study with two arms, one containing the standard 3-drug regimen and one experimental arm consisting of olanzapine 10 mg HS, which was based on the previous studies of olanzapine in high emetogenic drugs. The regimens that we are including is FOLFIRI, CAPIRI, Capox, modified FOLFOX, PEM-carbo, 3-weekly paclitaxel, and GEMOX in all solid tumors. Our planned recruitment is 560 patients, accrued for over 36 months, that is 3 years, and objective assessment in terms of CR rate, as well as maintain patient's diary for 7 days using visual analog scale to be collected by independent personnel who is blinded, and nausea will be assessed on scale of 1 to 100 with score less than 5 to be defined as no nausea. All serious adverse events, SUSARs as per the usual protocols to be taken, and fly questionnaire, which is the standardized questionnaire for anti-MSS trials, will be administered prior to the chemo administration. It will be used thrice during mid-cycle cycle, that is day 7 to 10, and prior to starting C2. Investigator will be blinded to the quality of life questionnaire till the time of completion of study and data analysis. And patient diary will have documentation of all episodes or rather any episode of nausea, vomiting, and use of rescue medications, if any, and scale of nausea every day for first 7 days. We are assuming the CR rate of 75% in standard arm with attrition rate of 10% and taking two-sided to alpha of 5% with power of 80%. where sample size is 560. Data is collected using CRF or eCRF, and reporting will be entered into validated statistical software. And adverse events will be documented using CTCA version 4.03. There is definitely an unmet need of adequate antiemetic regimen in moderate lymphogenic class, and the study drug which we are used is easily available, no major toxicity, no financial burden, and ease of administration and cost effective in previous studies. So potential benefits outweigh possible minimal side effects. This also potentially improving quality of life. This already IEC and IRB approved. With all patients with informed consent, study will proceed as per the declaration of Helsinki guidelines.